Today, we will be discussing some of the areas of documentation which are frequently missed or improperly charted within the ED. This includes nurse activities, fall risk, skin risk, suicide risk, sepsis, stroke assessment, WDL charting, patient data profile, social history, pain assessment, and discharge medication. First, we're going to discuss nurse activities, which is found on the right side of the ED launch point window. This is the preferred way to view and document any tasks that are due for your patient. This includes opening your triage and PDP forms. Another advantage of using nurse activities is that you'll be able to see and review any new orders that have been placed for your patient. Next, we'll talk about fall risk screens, which are frequently missed on patient charts. Each new patient in the ED has a fall risk screen task that is generated in nurse activities. This is required to be completed at the beginning of their stay. When you get to the secondary diagnosis question, you can right-click within the white box and select reference text, which will define exactly what falls under a secondary diagnosis. If the score determines that the patient is a fall risk icon will appear next to the patient's name on ED launch point. This will make it easy for staff to identify who's at risk. Skin risk assessment is another frequently missed task. Certain criteria, including a documented decreased level of consciousness, will create a task in nurse activities. When completing the task, be sure to document all areas of the assessment so that a Braden score is populated. If you document a skin breakdown risk of at risk or higher, the system will generate an order with an associated nurse activities task to turn your patient every 2 hours. Be sure to turn your patient and document on those turn tasks. When documenting via the turn task, the appropriate turn-related section will automatically open in iView for you. The initial CSSRS should be completed when the patient first arrives to the hospital. Be sure to also screen for thoughts of harming others, along with signs of abuse. When completing the CSSRS, the risk level will auto-populate based on the answers chosen. When choosing from the options within the suicide risk interventions, pay close attention to the include at a minimum asterisk. For example, if a patient is high risk, there are 11 risk interventions that must be checked. For high-risk patients, a patient safety attendant must be present at the bedside, while a moderate risk patient must have a patient safety attendant within line of sight to the patient. Both types of patients will need the paper suicide and ligature risk care plan completed, including Q15-minute checks and the patient safety plan. A turquoise wristband must be worn for high-risk patients. The band stays on until the lifetime suicide risk assessment is completed, and the patient screens as either at low or no risk. The lifetime suicide risk assessment is expected to be completed by a social worker. For discontinuation, providers will also need to document on several elements within their notes. This includes collaboration with the RN. When filling out the paper care plan, make sure all sections are completed. Include marking the appropriate checkboxes, initialing, signing, and adding a date and time to the form. Patient safety attendant documentation must start from the time the patient is deemed a high risk until there is an order from a provider to discontinue the PSA. If the observation goes over 6 hours, the next page will need to be filled out completely as well. Don't forget to mark under the start time section of the observation log, which can be easily missed. Avoid leaving blank lines on the page. You may draw a line through any unused lines when documentation is complete. Then when a provider gives the okay to remove the PSA, the nurse must document a physician communication under the time the discontinuation was given. The patient safety plan is to be completed upon discharge. Ensure that the patient signs, dates, and times the form. For potential sepsis patients, always ensure blood cultures are ordered and drawn prior to starting antibiotics. If you have difficulty with IV access, which causes a delay in antibiotic administration, or are unable to obtain a full set of blood cultures prior to administering, document a clinical note explaining the reason. One documented hypotensive blood pressure can push the patient into severe sepsis criteria. 2 hypotensive episodes will require fluid resuscitation. If the patient has hypotension after fluid resuscitation, vasopressors will be required. It is important to document that the physician has been communicated with for any hypotensive blood pressure readings. For all suspected stroke patients, ensure you document an accurate height and weight using a standing scale or scale on the gurney. Additionally, you will need to document a last known well. Complete neuroassessments must be documented and done at least every 2 hours until downgraded. Immediately notify and document physician communication if NIHSS increases by more than 2 points. Make sure a swallow evaluation is also documented prior to administering any oral medication. The required elements of a full stroke assessment are shown in this snapshot. Use the neurological ED header within the focus assessment ED band for the easiest way to document what's required. For patients who have received thrombolytics for stroke, be sure to document a full neuroassessment along with vitals every 15 minutes for the first 2 hours, followed by every 30 minutes for the next 6 hours, then every hour for the last 16 hours. This equates to a full 24 hours of frequent assessments post-thrombolytic administration. It's important that you also clearly communicate the timing of these assessments during nurse handoffs. While documenting your stroke assessments, refrain from using the no change from previous assessment option. It's very important to document vital signs for all intervals. Any missed documentation will be considered a fallout. If you were unable to complete vital signs or stroke assessments at the expected time, please add a clinical note under the time that it was due explaining the reasoning. For example, you were transporting a patient during that time and no continuous monitor was available. Ensure you document your stroke assessment interval times from the exact time you started and for the full amount of time. No rounding. If the first Q 15-minute vital sign starts at 9:16 a.m., you must start your Q 30-minute vitals 2 hours later at 11:16 a.m. WDL means within defined limits. But what does it mean when you're choosing to chart WDL within your assessments? If you're unsure what WDL means for a given body system, you can click on the blue text for the body system in question to be taken to the reference text for a description. It's helpful to note that you can click on any blue text in iView to be taken to reference text for a description. If your patient does not meet all the criteria stated in that reference, do not choose WDL as part of that assessment. The patient data profile intake can be found and documented in nurse activities. The minimum required charting sections of the patient data profile include home meds, infection control screen, social history, medical history, and procedure history. It's important to complete these sections prior to our physicians reviewing the patient chart because the information in the histories will auto-populate in the SMART templates of the physician's notes. And most of those histories are required documentation, which must be present in their notes. For example, hospitalists use home medication lists to help decide which medications they will be ordering during admission. And many of those questions in social history are becoming CMS standards and are required by certain insurances like Quest for screening. This can also affect reimbursement if not screened properly. When documenting from the home med list, Please do not use the Add button. This will create an active order on the patient's chart. You will use the Document Medication by History or External Rx History button to review, add, or remove any medications from the home med list. The External Rx History button gives you the option to import the last filled medications list and individually add them from that list to the home med list to document on the patient's history. Keep in mind that the External Rx History list may not necessarily have all the medications that the patient is currently taking. Manually adding the medications to the home med list can be done by using the Add button within the Document Medication by History window. Ensure that your search type has defaulted to Document Medication by History when adding to the home medication list. If the patient is unsure of the exact dose of the medication that they're on, you can still add the medication name to the home med list. You may already see medications that were previously populated within the home med list. Please review that list to make sure it is current. Medications with the pill bottle icon next to them mean that they have been populated by a medication prescribed through Castle. If the patient is no longer taking the medication listed, right-click to complete and remove it from the list. An example of this could be an antibiotic that the patient is no longer taking. Right-clicking also allows you to update the compliance on the medications. If that patient is not compliant with the home med, please also add a comment to describe why. The highlighted parts of this social history screenshot show where the current CMS and Quest Insurance required screening questions may be found. It's important to properly review your social history charting before signing your triage and patient data profile forms. There may be system-generated consult orders resulting from answers within social history. If you see multiple previous screenings within a category, it's important to remove and clean up the outdated entries to prevent unintended system-generated consult orders from being triggered. Now we'll talk about where to update the preferred pharmacy for the patient. There's usually a task in Nurse Activities, or you may find a button in the toolbar towards the top right of your screen. Updating the preferred pharmacy in a timely manner will help the physician easily e-prescribe medication to the patient's pharmacy of choice and prevent any delays in their workflow. Make sure to verify the chosen pharmacy address is correct, as multiple branches of the same pharmacy may be in close proximity. If your patient has any pain, a full pain evaluation assessment must be charted. This assessment can be found under Systems Assessment ED band. When documenting the assessment, be sure to include the patient's acceptable pain level, location, and pain scale, along with the other associated descriptions. The acceptable level of pain is frequently missed in the triage form. For your PRN medications, document the pain level, location, and include POS if it's an opioid. Remember that your pain scale documented must be within what's stated in the PRN range from the order details. Once your pain medication is documented in the MAR, the opioid or non-opioid med reassessment task will be generated and found in Nurse Activities. These PRN reassessments must be documented. We recommend to always grab the physical chart and bring it with you when discharging a patient. This will help avoid any instances of overlooking the issuance of physical prescription scripts, school or work notes, etc. Prior to printing discharge paperwork, ensure education for any newly prescribed medications have been added. For prescribed narcotics, ensure the physician prescribed Narcan and include the narcotic education pamphlet. Omnicell Narcan may be taken out and given to individuals who specifically request Narcan. When pulling out of Omnicell, choose as floor stock and have the attached paperwork filled out. For those who may want to further explore EHR topics, eCoach is a great tool to use for reference. You can access eCoach through the top of your toolbar in PowerChart or FirstNet, or on the Connect page in My Toolbox. Click on the nursing icon to see all related information, including job aids for charting and processes.